Hi, everyone. Welcome to our webinar all about the Mettle Method. We're just going to let people get in here and then we will get started. Thank you so much for joining us. We're going to go through just a little bit of information and then just get to questions because we assume that that's why you're here is to ask questions. So we'll tell you a little bit and then we can go over to you, and this will also be recorded, so we'll be putting it up. So if there's anything that you miss or want to revisit, it'll be out there in the world for you. So I'll just get this started. I'm Sonia Dolan. I'm a co-founder of Mettle Health. Natalie, would you like to introduce yourself?
Sure. I'm Natalie Crittenden. I am a mental health occupational therapist, and I'm a counselor on the team at Mental Health.
And she's wonderful. I just have to put that out there on top of it. So today, we're going to explain a little bit about the Mettle Method, which makes a ton of sense to me because I think that this is something that I have never seen out in the world. I think it's different. I think it's unique and special. So I think it makes sense that we need to explain a little bit more about it. And I think we're excited to do so. So one of the things that I kind of wanted to start out with is we call this a curriculum and we call it a training. And I think that's because we don't necessarily have the language for what this truly is. So we're using words that people are used to, but to myself, I don't know if it feels like a quote unquote training or a curriculum to me, because that's something where maybe you're like tested on the information later, or you have to prove that you learned something, and there's tests and there's questions that have right and wrong answers. And this is really a different way of thinking about things to me. It's a new way of putting yourself into relational care situations and thinking about how you react to them, how someone else might be feeling in this moment. Natalie's going to go over a lot of the topics we cover, but for me, I think it's very different. So when we say curriculum and training, it might just feel like that is the wrong word. And Natalie, we were talking about this yesterday. Have you come up with a better word yet?
No,
Yeah, I know.
no,
It's
no.
more, it's like a philosophy.
Yeah, it's a little part of all the things that have been normalized and are part of our culture and that we're familiar with. And it's smushed together with some stuff that we're not familiar with. And those things just haven't ever maybe necessarily been in tandem and in
Hmm.
relationship in life, training, experiences, work, roles before.
Yeah. Yes, I agree. I agree so hard. It really, to me, when I talk to people about it, I call it a human training, that it's something that each of us could do. Me as a human, Natalie is a human, my dad is a human, my neighbor is a human, my librarian is a human, my oncologist is a human. I think there's something in here for everybody that just has to do with reframing how we think about suffering and how we think about hard stuff and how we are with people in those moments and how we're also caring for ourselves. So I just wanted to start out with that kind of level setting, that yes, we're calling this a training, but we don't really have a word yet for what this thing is. But we know that there is a difference between when the person goes into the training and when they come out, just based on the feedback that we've gotten. So there's something that's shifting, but I don't know if it's something that is tangible in the way that we really like things to be surveyable and tangible, and how much percentage should you get better at X. So it's very different in those ways. So that's the first point. Second point that I wanted to bring up is that it's really for everyone. And when we first started it, the idea was that it was for clinicians, which I think is the largest group here. It makes the most sense because they are the people who are day to day caring for others. So it just makes the most sense, I think, for that group. But like I was saying about librarians and oncologists, this is for everybody. I've now gone through the training a couple times. I still get something out of it. We've had people who are not clinicians go through it and still get something out of it. So if you are someone living with an illness, if you are someone caring for someone with an illness, if you are someone who's been a caregiver and no longer are because that person died, if you are, I think, a clinician of like any zone where you are interacting with other people who are navigating an illness or disability or issue or end of life or grief, I think this is applicable to all of those areas, which I realize on one hand makes it almost harder because it's for everybody. But really, I do think that there's something here for any type of person who is navigating this world. Like it just brings up things that each of us will relate to. It is not disease specific. It is not something that's going to be going over medical diagnoses or scientific information in the way that medicine is. It's all the human aspects of what it is to be in these situations, and each of us, I think, can connect to that. Natalie, sorry, I'm rambling about this. What are your thoughts on the who? The who should be doing this?
I think that culturally, so often we're trying to figure out what box we fit in
Mhm.
and are challenged to believe that we belong. And so, again, this is a bit of a cultural shift where it's can be hard to believe that I would belong there when I'm not this, or I would really belong there even though I'm not that. And that pushes up against a lot of the norms where it's always only for healthcare providers, or you're only in this training or this educational track because of X, Y, or Z with certain boxes ticked. So if you're sensing any of that and thinking about the Mettle Method, it's real and true, and the challenge is there to step into. I do have a place to learn this and be in community with other people and experience a sense of belonging.
Mm, nice. Oh, love that. Well, should we just get into a little bit of the topics? And
Sure.
Natalie's going to lead this piece of it. I'm going to be slide advancer and I'll just interject every so often, but she's going to go over a lot of the ideas that are covered.
So this is how we start out when we think about the Mettle Method and we come together. And I'm tempted to read it out loud because I know people learn differently. And so I'll just go through with that. And my apologies if that's irritating and not how you want to experience this. But this is not meant to serve as an ideology one must accept. It is helpful and necessary that participants bring themselves into the conversation.
Mm,
So we're really going to go through some slides that are just a quick little bite summary of several different things so that folks know there's 19 slides. We're going to go through each of them. I'm not going to expand a lot. It's so that we can go from this sense where we think about structurally in society, we need to identify what role we are in
mm,
and then do that job. And that can even include being a loving partner to someone. But even we get messaging that we shouldn't necessarily always bring ourselves into that space. And so this is a big focus of the Mettle Method is, well, for you as an individual, incorporating your identity and your lived experiences not just in your paid positions or in your familial positions, but how you've experienced life up until this point.
mm,
What information do you have that would inform this moment or this experience or the way you are working and being in relationship to others?
mm.
So I'll just say we have 18 more brief, just snippets, and it's just little snippets because it's something that we want to be able to share with you all so that you have a sense of what is even out there within the possibilities of the Mettle
Yeah.
Method.
And I'm gonna add one thought to this slide, which is, I think specifically for clinical folks, this one is really meant to say everything that you've learned up to this point is great, is welcome. This is part of this. This is, we're adding on to what you already have. So this is in no way meant to be everything before this was wrong. And now there's a new way of thinking about it. It's bringing all of yourself to this and then maybe adding a new lens. So that's I think is an important point too, is like, everything you've already got, great. That's what we want you to bring to this.
One thing we think about is how we orient to health. When someone is in a state of health, it does not mean they have healed from an illness or are not experiencing discomfort or distress. So exploring this notion of messaging that can sometimes come where if you could just ignore this the rest of the time when we're not meeting and live your life, then we can reconvene on this later. And that there's actual implications for folks that are navigating their bodies and all the systems that are part of our bodies. And that there's lots of different states to exist when living with illness. Palliative care as an aesthetic practice. In general, we follow the feeling. The word aesthetics is often misunderstood.
Mm.
This is a very big conversation, and
Yeah.
it's weaved in throughout the entire Mettle Method time, when we are working together, considering aesthetics and how that can aid in healing or how it can actually create a sense of alienation
Mm.
when we are meant to be moving into a place of trusting people to get us to a place where we can feel a little bit more whole. Meaning, a beautiful and effective response to suffering of any kind is to make meaning from it.
And I'll add to this one, there's also meaninglessness, which is not in the slide, but that's part of part of the training as well.
Mm-hmm. Oh, Sonia, you're good with this one too. Created and irreducible selves. We think of people as having an irreducible self and a created self.
I love this one. I love thinking about where we as ourselves also just stop and the next person starts, and like all the things that go into it of like boundaries and opinions and agency and advocacy. So this is one of my I love just thinking about this, especially when it comes to caring for someone who might be sick, and like recognizing that this aspect of it is still present even when illness enters the picture, when illness becomes like the thing. So yeah, this concept in general is just one of my favorites.
Relational care. Oh, you also talk about this one a lot, Sonia. When we
Yeah.
approach people with expectations about what they should be moving towards, they're forced to confine what they feel into a form that pleases us.
Yeah, same as my, last comment is the relational care. I think this is kind of, for me, Natalie, this is in, I'd love your opinion. This is kind of like the core of all of this is us relating to another human being while caring for them. So that's, I think, a large aspect of this training, just period, is there is another person, there's us. How do we combine those two things?
Clarity. Our outcomes are measured by the person's experience of spaciousness and clarity, which is just wild, having gone through my training as an occupational therapist, where again, you brought up measuring, Sonia, and that's really important. And again, I'll go back to the point that you made earlier, which is I can't let go of my measuring when I
Mhm.
am treating. That's irresponsible. And how can I develop a sense of someone's level of clarity and where they are experiencing some space in the midst of their suffering, which is so nuanced and something I just hadn't had the opportunity to explore and to build the skill around.
Right. I feel like the word spaciousness, period, is not really a medical hospital healthcare term. Like, I don't know if that's a thing. It's very tiny. Things are very small. They fit into compartments. You can check them off on a box. You can say yes or no. Spaciousness is a different concept. But to your point, and it's the and part. It's like these two things can be there together.
Hmm.
Oh yeah, spaciousness. Here we go. We're just talking about this.
Again, without enough space, we remember, oh, sorry, with enough space, we remember that things that seem to be opposites are actually close neighbors. Safety and danger, burden and relief, living and dying. Accessing more space is a resilience builder and a modality for managing anxiety, which is so commonly inherent in living with a serious illness or actively being in the process of dying or losing someone who is dying. So this is a skill I think about and engage people in regularly to see where there might be the ability to gain more space while also reflecting on a lot of these experiences being dear friends and holding both in the multidimensional experience, holding both while having space.
Yeah, that holding both. You
And
mentioned this earlier.
oh, I did?
Well, I
Oh,
mean,
I
I feel like we each of us brings our ourselves, our experiences, that there is context for each of this, and recognizing that there is a context that is always, I think, present, just period, based on our experience, the other person's experience. So recognizing it. Sorry, didn't mean to take this one from you.
No, you can take it. I mean, including, did I have my morning tea or not?
Mm,
Right? That's part of my context for today. I didn't. So noting I didn't, and that will be present. That's part of my human context moving into the space when I'm going to serve someone. I didn't have my morning tea. So let's just keep that right at hand. And that's of note. And how to build our capacity to recognize what context in which we are existing and try to imagine as best we can and engage curiosity to understand the context in which the person we are serving is existing, living, and moving through the world.
mm.
Self-other paradox in client-clinician relationships, the idea of the self and the other is tricky.
And I
And
would say, sorry to cut you off there. This also, we say client clinician in this example, but I think it's everybody. It's me to you. It's me to my spouse. It's me to my dad. It's me to everybody. There's a self and there's another, just period. So in this instance, in this slide, we're talking about client clinician, which is like extra because you're coming in under the guise of a single issue, like a diagnosis, but this is just present for all of us. And I don't think it necessarily has to be client clinician.
yes, and I think it provides an opportunity for us to understand what research is showing us around co-regulation, how we regulate or can dysregulate one another, that our nervous systems line up. So when we're sitting to be in a space talking about a diagnosis, showing up to care for someone who is unwell, trying to love on someone, our nervous systems are chit-chatting. So when we talk about the idea of self and the other is tricky, it's because there is this system that is at work and that we have the opportunity to learn more about and understand and be able to lean into it because we understand it more.
Mm. My favorite word.
It is. Which is,
Integrity.
we can imagine listening and communication as components of a tensegral and structure. They are the bones, solid yet not inert, holding the form of the interaction. I like it when you riff on this.
I actually, so for everyone listening, this is just my favorite word because I think it's this huge, very profound word. And I just love that it's made its way into this training. I'm not going to give you too much more on it because it does have kind of a special place in it. But I also don't want to give the impression that the concepts within this training are so philosophical and high up there that they're not accessible. I think everything that we're talking about is also at the level of like, how does this actually show up in my life? So it's not just here's a concept to ruminate on. It's also this is how in your daily life or within your relationships this might show up.
Interstitial space, we can strive to witness another person's journey from a place of intimacy rather than one of emotional distance. I'm not sure what else there is to
Yeah,
say.
yeah, I agree.
Language, it seems like words are meant to describe reality, but reality so often flows from the word.
Hmm. This one, language, word choice, communication. I was saying that the relational care is like the core of it, but then I think this piece is how that core gets exercised within. Natalie, you were just talking about the nervous system, and that's part of it too, that they're talking to each other without us doing anything. So this is the talking that we are choosing to do. And there's so much wrapped up in communication. It's so hard. And I don't think there's been a lot of permission to say something where you're worried that you might say the wrong thing, or how to say something, or when to say something, and just kind of opening this up to give ourselves, I think, a little more grace in what it is okay to say to somebody else and to give yourself permission to screw it up and be able to say, oh my gosh, I didn't like what I just said. I'm sorry about that. Can we start over? And I don't think there's, for anybody, not just clinicians, I think all of us, there's this perception that you need to say the perfect thing in that hard moment to make someone feel better. And it's not always possible. So how can like silence and language as a piece of this?
We talk about advocacy, and this nears the end of the training, just we're getting closer to the end, where we can think about with these perspectives and skills and ideas, then how do we consider how to advocate? It's the subtle craft of speaking up for with a client whose voice might be lost in all of the medical shuffling. And again, we'll say the medical shuffling is so incredibly important. And so that needs to sustain itself. The advances need to continue, the research needs to be done, and the work within the medical world needs to continue. And how do we add on this layer of speaking up? Because ultimately it's this notion that when we do, that everyone will have a richer experience that hopefully allows for more people to feel aligned with their values and what they actually set out to do. Everyone is a part of the work.
Yeah. Yeah. And also just to, again, say that we have client here, but I think it's also advocating for yourself, advocating for someone you're caring for. There's a lot of advocacy that I think goes into these situations. So it's not just, yes, it's the medical piece, but it's also just, I cannot do this anymore. I don't want to have X happen. So it's advocating for your wishes, just period, and the things that you know that you can do or not do.
Activism and navigating the system. Palliative care is itself born as a corrective, nudging healthcare towards its fullest realization. Another sentence, I feel like.
Yeah. Mm-hmm. We're into palliative care, y'all, in case you couldn't figure that one out.
Boundaries. I love this topic. I love this topic. Okay, although boundaries are a crucial part of safety, they are too often used to artificially reduce a relationship.
Well,
And so many of us are taught and trained from family units or existing in certain neighborhoods or structural systems to really move around with such armor and ready to be on the defensive constantly. And my goodness, that's I feel quite a level of heart brokenheartedness around that reality and how we carry that through and then move through spaces in that way. And again, it is a crucial part of safety and having the space and time to examine where our boundaries exist and lie truly for safety purposes, and where we can create boundaries that allow for safety for anyone we're interacting with, while also increasing possibility for greater connection. Love.
I mean, here's kind of the example of what I was saying at the beginning of I don't know what to quite call this as far as like a training or curriculum. I don't know of many training or curriculums that are for clinical folks that include love. So this is kind of, I think, an example of where it gets into just being a human being, caring for other human beings. Sorry, go ahead.
Critically different from infatuation, investment, admiration, gain, or attraction. Exploring what that's like in a group with other people. Again, possibly the first time sitting alongside folks who want to intentionally explore and build skills in these areas, and name that this likely is part of the work, having the heart invested in certain ways, and that is actually an area to think about in terms of where am I at with my capacity to love and actually sit with and name with that that's what's happening for me, and that's okay.
Okay, our last one. We made it.
Made it. Well done, everyone. To my reading. Closure. Endings and relationships can feel hard on both sides and for importantly different reasons. And it's there's so many ways to do it. And there's so many ways to assess how someone else might need or want it to be done.
Mm,
And how can we be more open-minded around it all and really honor folks' needs to have it or not.
mm. I love that. Okay, let's stop sharing and we can get into questions. So if you want, hold on, let me open the chat too here. You can type your question into the Q&A and I will read it out. You can raise your hand and ask it out loud. We're here for any way that you want to interact with us. And I don't think there's any question that is off limits.
Well, to let you know, because we have boundaries.
Right, totally. It's the Mettle Method at work here in this webinar. Okay, we don't have any questions or hands up yet, so I'm trying to think what we can just add to this. I can add some good storytelling. Why not? About the training. So we've done it, a couple times now. We've done it with a group of clinicians. We've done it with some groups of more diverse folks, with someone who's a caregiver, someone who is a clinician, someone who's living with an illness. And some pretty cool stuff has happened through these trainings, and there are things that I don't think we were expecting, but they're really, really cool. People have said that their home, like their personal relationships have changed after going through the training, that they relate to their partner and their friends in different ways. We had two friends at a training who had an argument and were having a hard time with each other. And after the training, they were able to reconcile and see each other again and rekindle their friendship, which I thought was really cool and amazing. We've had people move into like different positions within their job and have a better sense of what it is their team needs, which amazing. Did not think that anything like that was going to happen. So there's some cool, like when we think of, outcomes of this, I think they're pretty broad in the sense of this is a human training. We're kind of hoping for people to reframe new ideas and concepts. Actually, this isn't something that I brought up in the beginning. If this also might be something that is difficult, that like feels weird, and some of the concept I've heard from attendees that some of it is kind of hard to wrap your head around or feels uncomfortable. Natalie, I don't know if you want to talk about that from the last training, but that's a real part too. And like, I think we invite that this is not meant to be, here's this thing, you have to accept it and then move it along. Like we want to engage in conversation around these concepts, and have that discussion if it feels weird or off or like not within the range of what you are interested in doing. So Natalie, you just went through that last one. What are your thoughts on that piece of it?
I do think that there are plenty of times where there is a level of discomfort.
Mm,
But that's interesting because it's not, I want to be clear that the experience is not all dialectic. So it's not just speaking, there's engagement and meaningful activities. And I think it's from that
mm,
place, when engaging in an activity, where there can be different varying levels of comfort as well as healthy risk taking in order
mm,
to build a skill. And so some people would elect to push themselves a little bit. Some people would say, okay, I need to take it down a little bit. And it's all can be regulated for each person when engaging in the activity. But I think that's where, so when there is sharing from the facilitators, then always there's the incorporation of what other folks think and the participants. And so there's sharing that happens, and definitely learning a lot from folks that are in the group. And that's part of the dynamic
mm,
that is so magical, because there's the opportunity to learn from people from, again, when we talk about the context in which I exist and you exist is really different. And so there's a
mm,
lot that I can gain in terms of insight and empathy and perspective and compassion and global thinking when you share. And it's not expected that everyone does that in one way, and people learn differently and learn from each other. And again, people's nervous systems are being regulated and dysregulated by other people. That's inherent to a group process
mm,
and what unfolds. And through the activities, the group sharing, the speaking by the facilitators, then I think that there is this way that yes, people can be pushed into feeling uncomfortable,
Hmm.
and then also building the skill to regain balance within that space, which is, again, I'm always thinking about skill building in these different contexts. So what happens when I get uncomfortable and I'm in a new environment, and then how do I find a path forward so that I
Hmm.
can be in a space of regulation and take in more.
Hmm. Ooh, we have a question. Excellent. Oh, Patty. Hi, Patty. Let's see. I want to see change in how patients and families are treated. What
Mm.
do you see as the prospects for this? Can metal help that process along? I hope so. Here's one example. I think that even when someone is seriously ill for the first time, they, not their doctors, can make the best choice for themselves.
Mm.
I mean, I think so, Patty, thank you for the question. I literally am thinking of like exact slides where I think that this concept comes in. And I think like you're saying, Patty, that the person living with the illness can make the best choice for themselves. Yes, I also agree. So I think part of this training is the advocacy piece. So speaking to the idea that you're advocating for yourself, but then also like the self and the other, and that's speaking more to the clinician piece of it of like, where do you, the clinician, and your opinions and your context and your thoughts and all that stuff stop? And this person who's sitting in front of you with this illness begin? And where's like the little fuzzy parts where they're overlapping? But I think that's a big piece of it is recognizing this has been a big piece of it for me learning this training is where do I, Sonia, stop and I need to let this person start. And I think there's and boundaries is part of it too, but Natalie, thoughts on like where that comes into the training? Because I think that's a big piece of it is helping others realize that this person living with the illness might actually have an idea of what they need and how to listen to them without bringing your own medical context or things you have seen or other patients that you've had who did X and it worked out this way. Like they're bringing all of that to the situation versus me, the single patient. I'm just bringing my experience. So they've got all this other stuff that's coming into the room with them to see you where this is your first time. So yeah, I think that's a huge, huge part of it. Natalie, thoughts on that
Well,
question?
and I would add to your laundry list of the provider who's coming into the room, sharing you have this new diagnosis, everything that you listed that they're coming into the room with, and we add to it the context in which they've been living, which is they had a dear loved one who died very quickly from this.
Mm-hmm.
So they're urgently going to make recommendations because they haven't had the opportunity to notice their own suffering and how the response from that suffering now informs their practice. Of
Mm-hmm.
course, it's going to inform their practice. Absolutely. And we actually don't want to get to a place where it does not inform their practice. But with the Mettle Method, we want to be able to have this space and time and reflection to say, I had a loved one that suffered so badly. As a result, I suffered, and I'm trying to alleviate suffering very quickly to the point where I'm not actually actively listening
Mm-hmm.
and allowing for the patient to have agency.
Yeah. Yep, definitely. And so, Patty, I think that's the hope here is, seeing how patients and families are treated is, and
Mm.
again, it's not necessarily like training the clinician to recognize this and like answer something on a quiz. Like, yes, I recognize that I am bringing my own context in, I have my own suffering. It's a bit of just getting them to even think about that concept, which I don't think has really been a part, like, we're all very in general. I think of mostly myself, like just it's just true. Like we're all kind of thinking of ourselves as we move through the world and how we would do something and how it's probably better than this person's choice and so on and so on. And that's a natural state of being. So I think it's just introducing the concept of, hey, this may not actually be the way to think about it. And it's just that little reframe that helps people think about it differently. And then hopefully those clinicians who are working with patients and families are entering that conversation or entering the room or whatever it may be with a recognition of where they are stopping and this person is starting and where they need to this is a, a little more drastic wording where they need to shut up and listen to this person and then integrate what they're saying into the knowledge that they have about this person's illness. Because we're talking about like, so I, the patient living with this illness, I have all the information about me. I am the expert of me. They are the expert of lung cancer, which I have. So we're taking two pieces of things and trying to put them together. And we don't want the expert of lung cancer and the expert of me to win over the other. I think there needs to be a combining, which hopefully will lead to like more care that makes sense for people, which I think is a goal for this, is helping people get to a place where they're electing the best care for them, whatever that might be, and being able to share that opinion with their families, with their clinical team, and having them respond. Yeah, Patty, right back though with anything. I love that thought.
It's interesting because it wasn't until I live with a serious illness and have the entirety of my life, but it wasn't until I sat down with a palliative care team wherein they asked me about what I value and what I am most scared of. And
Good question.
that helps for them to be able to understand the context in which I exist. So they can step into my world a little bit. Okay, if your top values are these three, but they don't align with my values, but this is how I start to understand you as a human being. Then, okay, now I understand your values. I understand what you're most scared of. Then that gives me information from which I can practice and communicate with you. I have to align myself with you. And so it's the check myself, align with you.
Yeah. So Patty added a little bit more. So can patients and families expand their doctor's space? How do we do this?
Oh, is it okay if I go? If I
Yes, please.
try? Okay, Patty, I'm
Yeah.
going to try.
Yeah.
And I am a huge fan of being incredibly explicit. So as a patient or a family member, when sitting with a doctor saying, I need some space for us to zoom out, and I would like to ask you to do that with me. Together, can we get some more spaciousness around this? And just be super clear and direct. And whatever is happening with their face, whatever feelings they're going to have, remember, everyone has feelings. They're going to have feelings about it, and pause. And then pause and say, I'm asking for us all together if we can get some space to consider an even fuller picture right now.
Yeah.
And just go in straight and hard.
I'm just going to bring up the slides. So we've got spaciousness in order to find clarity, and I think advocacy in that. Like, this is what I need. I'm telling you what I need. Can you meet me there in order to get a bigger picture so that I can find clarity? Like, ta-da. So Patty, that's the hope. Like that this is what this is doing, is kind of reframing it on both sides, because I don't think that there's a quote unquote problem on either side. It's that we're all kind of navigating this in a way that just isn't the best use of the human beings within the system. So we're kind of trying to get into the human part of what it is to navigate these experiences so that we are doing what you're mentioning. Sorry, Natalie, you were gonna say something.
Well, Patty, I think your question brings up exactly why everyone is invited and welcomed and will have
Yeah, totally.
a space for belonging at the Mettle Method, because you're now asking a question where members of a family or a unit or someone living with serious illness, disease, or dying, when they come to the Mettle Method, then the hope is that, yes, through their interactions with their providers, and as a provider and as a patient, I will say that is definitely within the realm of possibility. When I'm serving someone and they say something directly to me, Natalie, I need some space and I need you to slow down. How have I learned to slow down? Is because people have said something really directly to me, and I'm a provider. And so then I, in turn, have said to providers, I need you to slow down. I've even said, I need you to be nice to me. And so that your question brings up that there is a seat for everyone at the Mettle Method, because change happens from all directions. And we think if we just get one group educated, that then everything will evolve. And we're coming from this space of, if we all consider things together and go off in our different roles and different spaces and how we hold and our various identities and move through the world, that change will occur.
Yeah. Yeah, I love that point. It's such a good yes. Yes, this is why everyone is invited right there because it can't I don't think it can just be one group. If, patients and families are pushing and pushing and pushing and the other side of it is not getting any of this, like it's just gonna not necessarily make the strides that we're thinking about, but just like Natalie said, when it's everyone kind of looking at it a little bit differently, hopefully that does start to foment some kind of change in how people are interacting with each other because it is a two-sided thing. That's the hope here, is that you're not going to the hospital and getting treated at, like this is something that has been a discussion and understanding that it's not just something that you're receiving, like going to the store and buying some socks. Like you're not buying the surgery. This is a choice that you have made based on your values and ideas and discussion with your family and yourself and your clinicians. So it does kind of have to be both sided. So that would be the hope, is that we've got lots of different people in the room. I'm going to answer a question that I think people might have, mostly just for the recording, but please, everyone, raise a hand, ask a question. So pricing for this is like an ongoing kind of figuring out what makes the most sense. So what I want to say is, if this is something you're interested in and you think it would be cool and you think it would be helpful and you want to do it, just let us know. Email us, info@mettlehealth.com, and tell us, and we will more than likely figure out a way to make it happen. This is something that we think is really important, and we want to make it possible for people. And we realize that there are a lot of people out there where pricing may be a barrier, and we don't want to do that. Also recognize that just emailing to ask is a little bit of a barrier. So thank you for doing that, for being brave and asking. But really, we're here for those questions. So the hope is that people who can afford a little bit more can support others who may not. So that's the model we're working with right now. And also trying to figure out other ways to deliver the training that might be a lower lift as far as financial fees go. So that's a big one. So just know we're here for discussion, for thoughts, for questions. Many times, the people who are working with us, our clients or Mettle Method attendees, you have the best ideas. Our counselors have beautiful ideas about how things could be done. So please let us know. We're just like this Mettle Method is meant to be this interaction between lots of different people learning how to reframe. We want to be part of this community in which we are educating and serving. So if there's ever a moment where you're like, why don't you do this? Let us know, please.
Are there any other direct questions you want to ask folks that are attending, Sonia?
Oh, yes, we have a poll. My gosh, thank you. Thank you, Natalie.
Welcome. I don't know if the polls are ready. But.
Okay, yes, they are. So this, I'm just gonna send y'all a little question. If you want to ask, or you want to answer, excuse me, please do. We're wondering, we've been talking about this, in your mind, does this really make sense to do it in person? Would you want to do this on your own and just kind of think about these concepts in your own solo time? Would you want to physically be present with other people talking about these things, or do you prefer to do it while folding laundry or just sitting in your own computer where you have your space to be for the rest of the day? So if you feel so inclined, please just let us know your thoughts. We'd love to hear from you. Let me see what other thing. I'm trying to think of what other questions have kind of come up since we started doing the curriculum that we can answer. I think we got most of it.
Yeah, and I think, under Sonia's incredible leadership and guidance, you have such openness to any possibility. And so, Sonia and I will chat and think about, what is there a group that exists that would like this level of support? So even if you're affiliated with service providers or a community that has been built through grief and want some type of level of support and skill building in the face of grief and knowing that there's more ahead. In terms of considering how the Mettle Method may be able to be incorporated into any space in which you exist, I want to name Sonia is, I think that you may forget sometimes, Sonia, how open-minded you are and how willing you are to engage in conversation. So I want to encourage folks that are listening that if you think, oh, within the space where I teach or my family is receiving care or this community clinic or anything, that if there's any support to be done, that Sonia is open and willing to converse
No,
and
thank you.
yeah.
Let's see. Patty said, have the healthcare folks who've attended let you know how they've used what they've learned after the Mettle Method? You know, Patty, I think this, I'll answer this, and Natalie, please chime in too. I think it goes back to that idea of these kind of intangibles. Like we heard from the healthcare folks that like it felt different going to work, that they had a renewed sense of why they were doing what they were doing, a new way of connecting with their peers, a different way of seeing their patients and families that they hadn't had before. So I think it's, I don't know if I can say like they, 50% of the time they felt better at work or anything like that. Like it really was a shift in how they were interacting both with their colleagues and with the people they were caring for in a way that felt better for them. So I have to believe, this is just me, that when the person, feel better about what I am doing, I am providing better care to the people around me. Like I just think that in general, I think that that's at the grocery store, I think that's at a hospital, like it just is. So the fact that the people receiving the training felt that they had new ways and new tools of connecting with people, that's one of the things we also heard was like, I have new options of how to connect with the people that I'm caring for. So one of the concepts that came up a lot in our surveys was the aesthetics aspect of this, is connecting to the senses. And that's not something that I know to be a big part of medical training, or actually, quite frankly, Natalie and I were talking about this yesterday, human training. Like we learn about the senses as sight, smell, taste, science, but we don't think about them as how to connect with the now and the present and connect with myself and be in this moment and enjoy myself. So there are still tools within this, conversation openers, communication moments, sitting with silence, not having to fill the space, ways of being with another person that we're suggesting, or ways of tweaking the way you are with people that I think make other people feel better about how they're showing up. If that answers your question. Yeah. So there are we definitely got like, I feel like I have new tools in ways to do this, that it wasn't necessarily like I had this conversation, it was so different. It was, now I know that I can say, I don't know, or I can say, sorry, I didn't like that, or I can just sit in silence and just say, this is so hard, and not try to make it better, but also recognizing, I mean, for me, I think recognizing your own internal stuff too, like, is a huge piece of this. It's like, yes, we're talking about how we relate to another person, but a lot of this stuff for me is your own internal processing of all these ideas and how you show up. And again, I think that's what then creates something that feels better for all of these interactions. Let's see, any other questions?
You said I had an extended conversation with a healthcare provider after the last round of the Mettle Method. And so I echo everything that you said.
Oh, good. I'm glad to hear that.
Particularly the tools, this is similar to what you said, Sonia, the tools allowed for them to show up in a way where they are noticing what's happening for them, and they're able to take care of themselves, and in turn show up and take care in a much more thoughtful, tender, kind, as well as boundaried way.
Yeah.
They feel as though they're practicing in a way that much more aligns with what they had envisioned and hoped for their career.
Yeah. That's, I feel like we're getting close to the end here, and so maybe we'll just riff on that for a second, which is my favorite part about Mettle, just in general. But then this, I think, is the reason we created the Mettle Method, like in the very beginning, was just how do we get the people who are working with us to understand the concepts that we care about and the things that we think are important? And a big piece of Mettle is that people, like clinicians, will email us and just say, this is how I want to work. This is why I got into healthcare in the first place. So I'm thrilled that this person said that, because that's what it is cultivating, is like people go into healthcare not to like administer tests and like do surgery and have administrative like paperwork moments. They go in to care for another person. So this is hopefully reconnecting them to that and recognizing where they can find connection moments, even within a system that is not great for connection moments. So there's also a big acknowledgement that the healthcare system itself is not able to go through this training. So we have to do the human beings within it and recognize that they're going to have to identify moments where they can bring that humanness in and moments where they can. But I still think that a small human moment is still better than no human moment, no matter what the circumstance. Any other questions? Okay, I'm gonna echo something Natalie just said, just so we have it on the recording, is we're so here for trainings, just like Natalie said. I mean, it could be, I think of like elementary schools, like everyone is having to deal with so much relational, like with parents, with other colleagues. There's so many workplaces that are having to, it's relational care. We're all in relational care,
Mhm.
I think, with each other all the time in workplaces, in our homes. So again, it's really not meant to just be clinical. We're starting with that because these are our people. This is where we come from. But anyone who's interested in any of this, like, let us know. We love the idea of people who are not clinicians going through this and finding a way to connect it to their experiences and their lives. So yeah, just thank you, Natalie, for that plug. We're here for that.
Mhm.
All right. Well, oh, Patty. Suggestion. Include what these clinicians said. Yep. Mm-hmm. No, Patty, you didn't miss anything. She's just suggesting that we include what they've said about interacting with patients. Yes, you are spot on, Patty. Mental note. Yes, we will do that. I love that. Anything? Thank you so much for joining us to chat about this. Oh, wait, we got a little something in the chat.
Mm.
Oh, thanks, Sarah. Thank you so much for being here. Yeah, no, it's our pleasure. It feels important to kind of explain this because it's a new idea, it's a new concept, it's a new idea. It's not one of those things where it's like at the end of this, you will be able to, fix a sink. Like it's very much a new way of thinking that hopefully you'll carry with you throughout the rest of your life and kind of reframe it as you go too. Like these are just concepts that I think follow us throughout time. So you now versus you from 10 years from now may have a completely different idea of what spaciousness and clarity looks like. And that's kind of the thought. Thanks,
Mm.
Robin. Thanks for being here. Thank you, Laura. Thank you everyone for being here so much. We really appreciate it. We'll post this for anyone who wasn't able to join so that people have answers, but thank you everyone for being here. Thank you, Natalie. Thank you so
Thanks,
much.
Sophia.
All right, everyone. Have a good Wednesday. Talk to you soon. Bye.